Hi, everybody. Welcome to our 2023 Self-Direction Virtual Conference Series. My name is Molly Morris, and I am a Vice President at Applied Self-Direction. Thank you so much for joining us today for the session Beyond the Basics, Advancing High-Quality Self-Direction in a Managed Care Context. I'm just going to run through a few quick housekeeping items before we get started. First, your microphone has been automatically muted, and due to the volume of attendees, please remain muted. You can submit your questions and comments at any time during the session by using that Q&A pod in the lower left-hand corner of the Adobe Room. And we do have time reserved at the end of the session for your questions. All questions and comments will remain anonymous. This session is being recorded and it will be available on our website after today's session. Closed captions for the entire conference series is available courtesy of our premier sponsor, Evero. You can access the closed captions by clicking that CC icon at the top of the Adobe Room. So I am thrilled to introduce our speaker for today, Holly Campbell. Holly is a director of Medicaid Specialized Populations and Programs with Elevance Health. She worked for the state of Tennessee Department of Intellectual and Developmental Disabilities. She was the executive director of a nonprofit organization supporting individuals with IDD, living and working in the community, and most recently, serving specialized populations in managed care for the past 7 years. So Holly, thank you so much for joining us, and take it away whenever you're ready.
Thanks, Molly. Good afternoon. It's a pleasure to be here today. Um, so today I'm going to share some information with you about using data to inform your practices to drive high quality self-direction programs. The world of data and how we use it is ever changing, and fortunately, we have the opportunity as programs and our capabilities evolve to gain better insight into how we can use that information to both improve our programs and support people in a better way. Before I move into talking about the ways we can use data, I feel like I need to take a moment to add how important it is to create space to listen to the people we support and to those who support them. While today I'm talking specifically on data, no analysis should ever occur in a vacuum and without engaging people who are using services. So I would encourage you to find opportunities to share some of the data points we'll talk about today to gain the perspectives of program participants on what it might tell us or what we may be missing entirely. So we will dive in. Um, Before I get into the overview, it probably goes without saying that self-directed programs are often viewed as the most person-centered mode of service delivery. It promotes personal choice and control and ensures participants have decision-making authority. So, of course, what's not to like about that? And I know I'm preaching to the choir when I say this, especially to this audience attending an ASD conference, how important it is to understand what's working and not working about these programs and how we can improve upon them in the years to come. And as we're all too aware, the workforce challenges we face today and will continue to face in the coming years highlight the need for expansion, enhancement, and improvement in self direction programs. And so, using data is one way to gain some quality insights into our programs, and that's what I'm going to talk about today. So this slide provides a high-level overview of today's presentation. I'll touch on enrollment data and ways we can use it to help us understand how our enrollment processes are working or not working. Disenrollment data and what that tells us and why it's important. Basic day-to-day program management data that we all probably use, and how can use that to inform our practices engaging in the program, and some comparison data for participants using self-direction services compared to traditional agency services. And overall, summarizing some insights we can gain from this information, as well as opportunities we may have. Starting with basic enrollment information, again, this is pretty basic. When we look at program participation, these totals are often referenced. We see them in articles, reports, scorecards, but sometimes we don't know what percentage of that total we own that's within our organization, whether you're an MCO or another entity. Do we really understand how we are contributing to the whole? And so, looking at this to kind of break down those totals into a few basic points. The first is how many people are participating in these programs statewide? And when I say that, I mean all programs. So, even if your organization supports one program, how many people are participating in all of the statewide programs that may cross LTSS programs, IDD, veterans programs, etc. And then look at how many people who are eligible are participating statewide. So, what percentage of those individuals who could engage in the program are across the state? And then looking kind of at your organization's level, how many in within your health plan or within your organization are choosing self-direction? And what percentage of the eligible population is that? It's important to call out eligibility here because that may mean you want to remove, for example, nursing facility, um, individual that are people that are living in a nursing facility from that because typically not eligible for self direction. So making sure you're considering the eligible population compared to those who are choosing to use self directed services. This helps you understand how you contribute to the whole, but also gives some insight to begin exploring what else this may show you and if you should consider steps to promote more participation, like retraining of coordination staff. And this question came up for me, and you may have heard this as well, as what percentage of participation is good? What are we really striving for here? And the answer to that question is going to vary based on a lot of different factors, such as state priorities, program design, program mix. However, when I asked our friends at ASD about this years ago, when this question came up for me, the answer was usually look to about 30% of the population is generally where you want to be. But again, we we don't want to shoot for a specific number. Some will have more, some will have less, and hitting a total is less important than really understanding where you are within your statewide and even national landscape. So I do want to say and just call out, I don't think it should ever be a practice to encourage people to participate in self-direction programs to simply hit some type of enrollment total goal. Choosing self direction is a personal choice and one that comes with some hefty responsibility. So, should only be elected when the person has made an informed decision about all of their service options and understands their role within that. We wouldn't want to assign quotas to caseloads or anything like that. So, just a quick call out that's not at all what I'm encouraging. It's simply a matter of kind of knowing where you stand. And so, how can you use this? If we're not going to shoot for that, to meet a certain mark, how could you use this information? Well, internally, you can set goals in other ways that look to improve access, but don't push people into that option if that's not what they want. So, for example, you could focus on improving your internal training. Look at how you're educating participants about their options. Is there an opportunity to improve that? Additional materials that clarify the program, those types of things. You can compare it to use it to compare your organization to like organizations to see where you stand. Another really valuable step is to share that with your state partners. And really, as we go throughout the presentation today, there's a lot of really good opportunities with the data to share with state partners to help inform their decisions as well, potentially even around program design. And we'll talk about, as like I said, a lot of different ways that this can be used as we move through. So beyond basic enrollment, there are several points where we can measure key steps within the process, kind of starting with referrals. When we examine referrals, there are several steps from that initial referral until the person starts services that we can look at. But determining which ones deliver value to you will require some exploration. So, as you look at the steps in the process, for some organizations, different steps may stand out as more of a pain point or a concern than others. And so that's going to be individualized. You can look at referrals. So how many individuals are taking that option? They're electing self-direction, and we're sending referrals to an FMS. And then how many follow through to start services? And what do you look at during this process? So, for those who aren't completing the process, are you tracking that and evaluating why? And are we losing people potentially at what phase are we losing people? Are we losing them when they start and are introduced to paperwork, to, or I call it paperwork, a lot of this is electronic now, but to the process where they enroll as the employer? Is that too daunting? Is that where they stop and say, wow, this isn't what I thought it was? Are we losing them at the phase where they're identifying a worker? And we all know that's often the case. And when we look at those referrals that didn't make it past go, those that didn't complete that paperwork, should we examine how our teams are talking to people about the program? Did they start off invested, but once they hit that paperwork, they realized it was more than they wanted to take on? And that's okay. Sometimes that happens even with the best of education. People are going to change their minds. The point is to explore it, to see if there's something we could do better to help people stay engaged. And of course, that's where talking to people and creating that space to hear how that's going for the people you support is so important. Another step to take is reviewing service coordinator caseloads to examine how many referrals each service coordinator is making for self direction programs. And I say referrals, but this is obviously when the person's elected to go that option, and whatever subsequent steps follow in your situation, whether that's a referral to an FMS or beginning working with another entity to get the ball rolling. So there's a lot to think about here when you look at service coordinator caseloads. It should not be a punitive exercise, but it's something you could consider caseload mix. Um, could there be a lack of understanding on the part of the coordinator? Is retraining something that would help? Is there kind of a bias around it because there's some additional paperwork, some additional steps? Um, those are all factors to look at. And again, not intended to be a punitive, and you don't want to set a goal to say every person should have this number of people on their caseload. But it's worth looking at because it may help you identify a problem that the person just hasn't raised their hand yet to say, I'm really not understanding how to talk about this. Another common measure is the initial referral to when services are started. And this accounts from that initial referral to an FMS or supports broker, whatever your process is, until the actual first day where the person is receiving the care that they are being authorized to receive. How many people don't complete that process? And we kind of touched on this earlier. Does it stop at the employer? Does it stop at the worker? The other piece that can fall into this is all of the other things, such as background check processes. Um, are there things that are hanging us up? For example, fingerprinting. Some states require that, some don't. Are those things that can be shared with our state partners or other partners to say, okay, we see we're hitting a lag here. This is really impacting the speed at which people can begin services. And can we revisit this? And can we look at if it's really given us what we need? Another element to consider, and one we'll dive into a little bit more detail in a later slide, is disenrollment, is to really understand why people are leaving the program. Is that nursing facility admissions? Are they moving out of state? Are they changing their health plan or moving to another organization? Or is that individual choice? Lack of workers is something that I'm sure we're all familiar with, but individual choice, sometimes when we have these broad categories like that can be considered when we look at state reports and things like that. A lot of things can fall into that bucket. Lack of workers is one, but sometimes it's lack of having someone to serve as that employer of record, or the person's circumstances change and it's too much to manage. So we'll touch on that more in a few minutes, but um, some of the things that we can gather beyond just that basic count of how many people do we have in the program. So, as I have done, you might ask, what is good enrollment data? Do you have an idea of what that means for your organization? And does that mean programs are good? I don't have answers for you because that's going to look different from every angle, but I can share some data from one of our Elevance Health plans. And this data reflects new enrollment over a 3-year period. And when we examined how many of the referrals were actually resulting in start of services, we found that on average over this 3-year period, and of course we've got that wild card COVID year thrown in here, but 62% of the referrals we initiated for self-directed services resulted in the person beginning their services. Now, if they didn't continue with self-direction, obviously they went to agency services. But when we looked at this, we said, is this good? There's not a whole lot of information out there to know how do we stack up. And so when I examined this, I talked again to our friends at ASD, and their response was, yeah, this looks pretty good. I was happy with that, of course, because we wanted it to look good. But I immediately thought about, well, what about the 38% here over these 3 years that didn't follow through? And so I'm gonna try not to go into problem solving today because I said I was going to talk about data, but we did look at two major categories. And really, it was the person stopped at the front door. They didn't continue to complete their enrollment. Um, and that was really interesting to know that we had people that were referred, and once they got the information to start their enrollment process, they didn't continue. And then, of course, we had finding a worker was the other most common. Not that there weren't other factors, but those were the two most common. So to stay focused on using data, I'm not going to go down a rabbit hole here, but wanted to share it as an example of how you might find those valuable nuggets of information that can help you improve your programs and your processes. So there are lessons learned here from this information to improve that process. The other thing this does is kind of gives you a baseline. So a point where you can begin to measure where you are. And then as you identify steps to improve the processes or put other measures in place, you then have something to reflect back to hopefully inform if what you're doing is working. Ideally, you would want this to serve as that evidence that we put something new in place, we tried a different strategy, we did some additional training, we did XYZ, and now it looks like, according to the data, that we're making a dent in that and we're really improving it. So now I'm going to move a little bit more into disenrollment and talk in more detail around that. So at a high level, what we have found for the most part, and this is of course very high level, is that people leave for two main reasons. One is just leaving Medicaid, whether that's transitioning to another health plan, whether that's um, unfortunately maybe the person passed away. And of course, there's transitions into a facility, but then not having a worker. So those are some of the two main reasons. And of course, as the slide notes here, it's just really important to understand why people are leaving to inform our practices and help us do better. So at this point with disenrollment, we're obviously being retrospective. The disenrollment has occurred. Um, we can use that information to inform our future practices. Ideally, we'd want to know things are getting rocky before disenrollment occurs and have strategies established to intervene quickly to avoid that disenrollment if we can. For example, if a participant loses a worker and they want to continue self direction, but they need some time to find another worker, what's your process for helping a person even hop out of self direction and use an agency while they find another worker to and hop back in? Is that how we react to it? Um, are we preparing and making sure that people have enough worker pool so that if they lose a worker, it doesn't kick them out of being able to be in the program. And I don't mean kick them out. I mean it means they're not going to get services. So we want to focus on being proactive as much as possible. Those are just a couple of examples. I'm sure there are many more. So some of the things we've learned from trying to track this data and thinking, how can we do better? Is when we have state reports and those state reports change, it's really difficult for us, and I'm sure anybody, to do year over year comparison. So there's some value with, within your organization internally to develop some standardized reporting metrics that would obviously also capture your state requirements, but maybe dig a little deeper or narrow it down a little bit more so the data you're getting is a little more meaningful for the purpose that you want to use it. Um, the other thing was categories like individual request or other are really challenging. Typically, what we would find was that an individual request, if the person just chose to opt out, that was also tied to lack of having a worker. So it doesn't really help us understand, kind of when we're trying to aggregate this data, how much of a problem that is. And then the other category, just a catch all, again, pretty hard to determine what that could be. Insight for disenrollment, though, can be gathered from your service coordinators because that level of detail isn't often captured in support in reports. So there's a lot of opportunity to look at, how can you consider that within your process. And then also dedicating time for a regular review, either a monthly or quarterly review of disenrollment can provide some insight into how we can change things, make things better, head things off earlier. But again, that's reactive. So I think there is some value in that, but there's also a lot of value in using that to inform your strategies to be more proactive, to get ahead of that before the disenrollments occur as much as possible. One final factor to point out with disenrollment data is how important it is to consider this as you look at program growth. So we often look at our new program enrollment. We see that we have hundreds of individuals enrolling monthly, and we see that as a positive. And of course, it is. But if we aren't watching the back door, we may not notice that we're losing participation. And our overall program growth is flatter than we realize. So that's something to consider as you look at growth goals is your level of retention within the program and obviously satisfaction. And as we think about being proactive, if a situation comes up and the person is considering opting out of that option, we're not suggesting to encourage people to use self-directed options if that isn't the right fit for them right now. But if we can provide support to help them stay engaged or get through a particular situation, that's great. And if that's what they want to do, making sure they understand their options obviously is first and foremost. Okay, so program management data. Um, this isn't everything. So there's four main categories here, and I want to point out that there's a lot of data. Those of you that operate these programs know we have a lot of information. So there's a lot to examine. I've mentioned satisfaction surveys before, which I'm not touching on in detail today, but obviously those can help inform quality practices within your programs. And the four I have outlined here are just a few major buckets. And I've talked about self-direction election data, say that three times fast. Um, we touched on this earlier, so I'm not going to repeat a lot about that, but this is the data that notes a person has opted into the self-direction program and usually kicks off some type of referral process to an FMS or support broker. It's just very early in the process. And you can sometimes identify elements such as the person having an EOR representative that will help them manage the program, the services they're choosing to self direct, which of course is going to differ based on your program design. But um, those are all elements that you can identify early to know where maybe some support needs could be, or some supports could be plugged in if there are needs. For example, helping an EOR or helping a person that doesn't have an EOR to make sure they've got everything they need. Service utilization and EVV data, there's a lot of overlap here, obviously. Kind of one and the same, kind of not, depending on how you look at it. But this tells us the amount of services used, can tell us about any gaps in care, can tell us how much of the budget is used. Um, it can also tell us even where services are provided if we have these GPS features turned on. And of course, that varies by state. If the person has a budget, are they using up most of their services early in the month? Is that a repeat occurrence? We've probably all seen that where someone has a monthly budget if they're on a budget model, and you've got 2 weeks left in the month and they've used it, and we're thinking, well, what's gonna, we got to make sure this person has the care they need for the rest of the month. And yes, that's the responsibility they took on when they went to manage their program. But sometimes people have things come up, and it's important for us to use that information and check in and think about how we're talking to them and how we're helping them learn to manage that. Is a person paying overtime routinely because they only have one worker and can't find another? So that's using up more of their budget when they could get more care. So thinking about these situations and looking at data, we could go on for a really long time about service utilization data. But really, it's about, do you have a way to address these types of issues? So, well, first of all, are you looking at it? Are you keeping an eye on it? And do you have a way to address it? And how does it impact quality? Obviously, if the person has used up their budget in 2 weeks and they've got 2 more weeks in the month potentially without care, I would think that that could have a quality impact on their health. The next category is collaboration with the FMS, and that can really provide a lot of meaningful insight into your program data, especially around your workers, or not your workers, but the workers affiliated with the people you support. So, for example, do you know much about the worker demographic? What percentage are family members? What percentage are living in the home? What do you know about worker tenure? On average, how long do your workers stay with the individual that you support? And based on that information, is there anything you could do to encourage worker longevity? I think for the most part, everybody agrees that we see better results with workers that stay longer because they know the person, typically have a close relationship with them, and in the case of family members, are typically easily accessible. Um, Does quality improve when tenure is better? And I think the answer is generally yes. That's what most people think. When you look at the workforce development information across the board, it's whether they're in self-direction programs or not. It's felt that that tenure, that familiarity, and that commitment, results in better care. So there's a lot of value that can come from examining that. And again, it's going to depend on what is your data story? What are these things telling you, and where does that trail take you on where the opportunities are to use this data to improve quality programs? And what does quality mean to your organization? And then lastly, comparing information for people participating in self-direction programs to data for people receiving services via traditional agency model is definitely worth exploring. So, thinking of some quality metrics in this area, course satisfaction surveys are useful to kind of compare those experiences. But there's also value in comparing the frequency of acute care utilization of these two populations. For example, when comparing utilization for these different programs, We find that members in self-directed programs tend to experience fewer instances of acute care. So this includes ER visits, inpatient stays, and they also tend to experience shorter stays. So while this usually results in lower spending, which is good, more importantly, I think it might point to a few other factors, such as individual autonomy, choice about using an ER, possibly better preventative care or better care in general. That's a question mark. I'm questioning this, but I think there's a lot that could be packed into this. And considering the caregiver workforce supporting individuals in self direction programs, because those supporters tend to be family or friends, have a direct employee employer relationship with the individual we support is calling the shots, and they should be. So, does that mean going to the ER isn't the preference? One of the things that stood out to me as a former agency director was how much some of the ER utilization, especially, could be driven by other policies and practices that agencies may have that aren't part of the day to day practices that occur in self direction programs. If a person has a fall or kind of a minor injury, is that policy driven that a person needs to go be checked out in an ER because of concerns around abuse or neglect? And while those are obviously valid concerns, is it erring on the other side where people are possibly going to ERs when they don't need to? In a self direction program, the person, aside from obviously being in some type of physical distress, is going to call the shots around if they're going to go to an ER or not. And so I do think those are some things to look at, valuable information to be found. So to wrap this up, um, I think I've driven home the point around using data and how valuable it can be. From a broad perspective, it can help identify gaps and barriers, identify opportunities we can share with our state partners, can inform enhancements to our internal processes, and give us a baseline with which to measure ourselves against later as we implement strategies to help move the needle in a positive direction. And then for insights and opportunities, as I have listed here, there's a lot of opportunity for, to gain more insight into these elements of program growth, contribution to the overall landscape. What do our coordinators' caseloads look like? Are there opportunities to dig into service utilization, our initiation of services timelines? What are the other quality insights we can look at, and what we value and what the people we support value, and how we need to build that out? What are some enhancements we can make around reporting and training? And then also the value in collaboration, and opportunities we have for enhanced collaboration with our FMS. So that wraps up my presentation, and I will open it up for questions if we have any.
Thanks so much, Holly, for taking us through all of that. And I see we've already gotten some questions that I can start with, but I just do want to remind folks to just submit any additional questions in the Q&A pod on the left-hand side of your screen, and we would love to include those. So, Holly, one of the first questions that we got in, what data sources do you typically use, particularly for the statewide data?
Yeah, that one can be hard because sometimes your state may not post that publicly. So, in those situations, we would reach out to our state partners and ask if they have that. A lot of times, this type of data is being reported to CMS. And so sometimes states have it, but just I've noticed that some post it publicly and some don't. So I definitely would say outreach, to your state partners to see if you can get that, and that might even kick off a meaningful discussion about the data as well.
Great. That's really helpful. Another question here. Is it ever possible to reduce the amount of paperwork required for enrollment in self-direction? how might we determine what paperwork can be eliminated?
Well, I would love to think that it's possible. I think that's going to be dependent on um, each state and what their requirements are, and that's why I think this is such a valuable exercise. And whether it's a one-time exercise or something that you're going to do on a more routine basis, to kind of look at these points across the process to say, how long is this taking? And having that information in combination with talking to the people that you support and the people that are going through this process is to gather that feedback and help identify that and then determine who can make that change. Is that a change you can make at your level as an organization, or is that a change you could take to your state partners and provide them with some data to fuel, some decision making?
Great. Thanks, Holly. So our next question is, what can advocates do to encourage managed care organizations in our state to better understand self-direction and to prioritize it?
I think that one of the things people can do is reach out and connect and share, um, methods, be a part of that conversation to help unpack some of this. There's a lot of requirements that have to be met, and sometimes it's really challenging to step outside of that and look at the whole picture when you're trying to meet all of the deadlines and all of the requirements. So I would encourage that. I think in most cases there are kind of advisory committees and things like that that are established for I think a lot of the managed care programs. So I think that's a real opportunity. And then also just reaching out to health plan leadership and connecting with them and letting them know that that you can be a support to move that forward.
Excellent. Another one here. What can FMS providers do to be a good partner to MCOs, specifically in looking at self-direction data?
I think there's a lot FMS partners can do. I think one is because they will have so much access to information from referral to disenrollment, um, is having a conversation about, we have access to this, we can get this. What would you like? What would help you? How can we help you? Like have that conversation, and even pointing out things such as, we're really seeing a lag in I think example I used was a background check process or fingerprinting or things like that. Supply that information um, so that it can be used and in a way to help drive again decision making and change. And that stuff may not come super quickly. We know sometimes that stuff requires, waiver amendments. Um, but I definitely think there's value in it. Another is the um, the data around the workers. That is extremely interesting, and I think can really help people understand. We talk a lot about worker training, right? That's been big on the radar. We need more resources for people. So I think there's even ways that can inform and help us understand if we're providing education to someone that is brand new to the person, or is that training for someone that's a family member. And I think sometimes we might have a little bit different delivery of that. There's just so many nuances to consider, that I think it's a matter of sitting down and thinking from that beginning to end process. What do they have, and how can you partner to make use of that information that's gonna in a way that's gonna improve the program.
Great, really, really helpful. Another question that just came in. I have a more basic question. How does self-direction fit within a managed care organization? I'm aware of the Wisconsin model where self-direction is an alternative to MCOs carved out for managed care. That makes sense to me. In contrast, self-direction within a managed care organization, which decisions are made by an employer of record and which are made by a managed care organization?
Yeah. So, for Elevance Health, at least in the states where we operate self-direction programs as part of our managed care contract for long-term services and supports generally. We do have a few other programs that don't operate exactly like that, but for simplicity, I'll stick to that. Um, so our role is typically the each person that we support will have a care coordinator or service coordinator assigned to support them with assessment, development of their person centered support plan. And part of that is choosing how they want to receive their services. So, from the very beginning, when people enroll, the MCOs coordination teams provide that type of education. Sometimes, if eligibility determinations are made by other entities before enrollment, they may provide some of that information. So it's possible that that process can get kicked off at that stage as well. But generally, we have that conversation upon enrollment, and then, of course, annually or anytime it comes up for the person, if that's an option that they want to resurface and discuss again. And so we assess each person for just service needs in general. And then if they just determine they want to receive their services through a self directed program, we kick off the process to start their enrollment into that. That may be that they use traditional agency services as in the interim until they're able to get started, and they've gone through the process of all the enrollment paperwork and having their workers hired. Um, but that's generally, and then everything along the way, as far as our role in supporting them. The employer of record would, of course, still do what they do. They're responsible for hiring, firing, the day-to-day management. Our role is really to support the member and their employer if they have one that's different from themselves to manage that program effectively. So I hope that answered your question.
Excellent. Thanks, Holly. Another question. Do any of the financial management services providers in states with managed long term services and supports, Elevance Health plans, allow members or consumers and their supporters to complete and submit their self direction applications or enrollment packets as online forms?
Yes, yes, we do have that with one of our FMSs for sure. We that is an option.
Great. A follow-up question to the previous question. So sounds like the employer of record makes all decisions except for setting the size of the budget. Is that accurate?
Well, yeah, when it comes to self-direction services, the state contract will require that we, as coordination teams, assess the person's needs for services. So when we do that, we determine, based on their assessed need, a certain amount of service is needed, and that's a clinical determination that of course can be appealed and that type of thing. But once that is set, whether that's an employer authority model where there's a specific unit and rate assigned um, to that service, or if it's a budget authority where that's translated into a monthly or annual budget amount. um, Once it gets to that point, that is for the employer to manage. The coordinator is the one that makes that decision based on that assessment, how much service the person is approved to receive.
Great. Thanks, Holly. I see a couple more questions, but then we'll wrap up. So if you have any additional questions, please submit them now. So, how do you begin gathering referral data and determining where the barriers are?
So referral data, you start within your organization. I think in most cases, I think people are collecting or should have some type of information documented that a person has elected self-direction and um, have to report that and track that. There should be a process to make sure once you've initiated that it's rolling and that you've got timeline set and are tracking that. And then the other side of that is again your FMS, looking at that process. So along the way, picking some things that you know have to happen in order for the person to get started, which would be the referral, identification of workers, background checks, all the steps that are included there, if there's any specialized training needed, and then ultimately getting all the approvals in place, background check results back for the person to begin services. So that's a pretty high level. I know there's a lot of other steps along the way as this process goes back and forth, and engagement with either support brokers or service facilitators or FMS, whatever that looks like in your area. Um, but that is where I would start to say, what data do I have? What do I have access to right now? Look at that and then think about what would it be nice to have? What should I start to collect that might help inform me of some improvements we could make?
Great. Thanks, Holly. I see one last question. So unless anybody, oh, wait, there might be another one after this. But keep submitting any final questions while we have the time. Um, what are strategies that can be used to prevent disenrollment?
Well, that's going to be individualized, obviously, but I think obviously one of those is creating some type of way to know that people are struggling, that there is a problem. So obviously once we've gotten to a disenrollment point, then we can't do anything. So trying to prevent that would be looking at all this data to see where the problems are. Um, I'm sure there are other data points we could look at. Sometimes there's issues with claims payment, things like that. So that can make things challenging where workers quit and then the person, doesn't have a worker and they throw their hands up and say, I'm done. Um, so I think it starts with and I can't see the question, so I'm losing track. Um,
It's the disenrollment, preventing disenrollment question.
Preventing. Okay, sorry. The other thing would be um, talking talking to your coordination team. And I'd mentioned, a monthly or some type of a quarterly review, but I think any type of structured time that you set aside to talk about individuals that are enrolled and having them raise their hand to say, this person might be struggling and I'm not sure what to do. Because they probably know. They probably anticipate, or they may know there are some problems. So I think kind of having a way to identify those, what are those flags? So I think you have to look at the disenrollment data to know what are the reasons people have disenrolled in the past, and how do we get ahead of that? Have that conversation with your teams, have that conversation with your advisory groups, and develop a strategy of where are some opportunities we have to get ahead of this. I think that's your best bet when you're starting with, kind of from scratch on looking at that. But I think it's a combination of using that data and having a conversation with your teams.
Great. Another question, and I see another one is coming behind after this one. Sorry if I missed this, but was the 68% election rate for self-direction the point that the FMS is notified the individual wants to self-direct, or does it happen prior to that? Where does the tracking typically start in the data that you presented?
In the data that I presented, that was for when the FMS was notified, which
Gotcha.
should be which should match up with the people who who elected self-direction. We would hope that matches, and it should. But yeah, that is um, data that your FMS again should have to say when did we get the first notice that this person wanted to self-direct.
That makes sense. Okay, we've had a couple more questions come in. Nothing like saying one last question to get another question in, which is great. Is Elevance Health looking into how it may be able to coordinate duals who are or want to self direct under both Medicaid and a Medicare Advantage supplement plan that can now cover allowable long term services and supports and home and community based services as of around 2019, 2020?
So yes and no. So we do have a couple of markets where we see that being used. I am not a duals expert, so I will just stop there to say yes, we are looking at it and we are coordinating with duals, um, but it's not something that we're doing broadly right now across all of our plans. Um, but yes, it's on the radar for sure.
Great, really helpful. Another question. Would an exit survey for self direction be helpful in analyzing disenrollment? If so, would it be more meaningful for the MCO or the state to offer those surveys since they likely have more access to care plans and individual needs?
I think that's a good question. That's a good point. I think exit surveys could be helpful. Um, I guess I think about exit surveys with this situation, as you kind of hear about with the workforce, is that at that point the person has made the decision to go. So I think there's value in it to understand you what didn't go well for sure. But there might also be value in saying, why do you stay? Why do you stay in the program? What's good about it? Um, so we understand that as well. So I think there could be value in both of those.
Well, Holly, that was our last question. So I'm going to go ahead and wrap things up and just thank you so much for taking the time to do this presentation. I know there were a lot of really, really valuable nuggets and that I hope people were taking notes. And I thank everybody who was able to join us today for a great discussion. So, Holly and everybody, thank you.
Great. Thank you.